Hello, everybody, and welcome to this episode of CMN Live. I'm very delighted today to be joined by Alessia Cavazza from University College London. Hi, Alessia.
Hi, Karen. Thank you for inviting me.
Yes, it's great to have you here.
This chat.
Yeah, it's great to have you here today. So today we could talk about a lot of things, but we're going to focus on gene editing approaches to treat prenatal diseases, or rather early onset prenatal gene editing approaches to treat early onset inherited diseases. That's a focus area in your lab. So perhaps we could just start the conversation with a brief overview of what you mean when you talk about rare early onset rare genetic diseases. What type of diseases are we typically talking about?
Yeah, so early onset diseases is really like a broad definition of diseases that basically can affect intrauterine development. So they can actually, the outcome could be like pre-birth death, or that affects infant development. So either with symptoms arising at birth or immediately after birth. So they are usually very, very detrimental diseases. These kind of early onset diseases I'm talking about are usually like inborn errors of metabolism, like, for example, lysosomal storage disorders, and in general, disorders that cause extensive neurological damage. Then we can have some diseases like surfactant deficiencies that impede pulmonary function. Therefore, I mean, it's a problem after birth. Some coagulation disorders, some hemoglobinopathies, like, for example, alpha thalassemia, and also other genetic disorders that have chromosomal anomalies that can affect the function of multiple organs at the same time.
Right, thanks for that overview. So within your lab then, one of the diseases that you're very interested in is Krabbe disease. Mm-hmm. So perhaps you could just tell us, for people who don't know much about Krabbe disease or maybe have never heard of it, could you tell us a bit about the disease and maybe also what makes it such a good candidate for prenatal gene editing and why it's so urgent to treat prenatally before birth?
Yeah, so Krabbe is a lysosomal storage disorder. It's a part of this heterogeneous group of diseases called lysosomal storage diseases, where they are all genetic diseases caused by a genetic mutation in genes that encodes for lysosomal enzymes. This means that usually the lack of these lysosomal enzymes leads to the accumulation of substrates within the lysosomes, which consequently triggers cellular responses such as that ends up in cellular dysfunction, cellular death, or tissue damage. And Krabbe is one of them. Indeed, it's a genetic disease caused by a mutation in a gene, which encodes for an hydrolysis. It's galactocerebrosidase, which basically, that's the name of the gene, which basically hydrolyzes, metabolites the lipids in the brain, and these metabolites are necessary to create myelin in the nervous system, in the central nervous system and in peripheral nervous system. So the lack of this enzyme caused the accumulation of cytotoxic substrates, which in turn leads to death of myelinating cells, such as oligodendrocyte and Schwann cells, which means it leads to widespread demyelination. So basically, these babies are born and they are diagnosed usually by 4 months of age, and they die within the first 2 years of life of neurodegeneration. So they end up with irritability, muscle dysfunction, then weaknesses, blindness, hearing loss, seizure, until unfortunately they die. So it's a very devastating disease. And one reason why it's very important to define a treatment for this disease is that there's no treatment available. Not even hematopoietic stem cell transplantation that works for some other type of lysosomal storage disorder. And the reason it looks like the reason why none of the treatment are working is that there's a very narrow window of opportunity for therapeutics. And it looks like from preclinical data that the neurodegeneration and neuroinflammation, which are these two symptoms of Krabbe, are established already in the last trimester of pregnancy. This means that when the baby is born, it's probably already too late for a treatment.
Okay. Yeah, so that's why you want to come in and develop a prenatal gene editing approach. Could you tell us a little bit about what your approach looks like? What kind of gene editing modality have you been exploring? How are you delivering it? And also, how would you administer it prenatally in utero?
Yes, so in this specific case, we have developed a base editing platform, specifically an adenine base editing platform. This is because we are testing this in this Krabbe disease mouse model, which is called Twitcher mouse, which is reproduces with high fidelity the disease in humans. And this mouse model, the disease is caused by a point mutation that abrogates protein production, which is treatable with base editing, so precise change of one DNA base. And we have packed these base editors inside virus-like particles, which basically are virus-like shells, which have a viral envelope, but are devoid of any viral DNA or viral genomes. So they don't integrate and they don't have any viral sequences. So they just take advantage of viral shells to enter the cell. And so with these VLPs, we have devised a platform in which we deliver them intravenously. In the case of a fetus, it means injection into the vitelline vein, which will direct these virus-like particles into the liver first, and then to other tissues in the fetuses, and eventually to the brain. This is because one of the advantages of fetal gene therapy is that the blood-brain barrier, which is a barrier that closes the brain and protects it from pathogens in the bloodstream from outside to enter, it's quite permeable. So these allow us to intervene with a very non-invasive administration, like intravenous, allowing us to target hematopoietic organs, but also the brain at the very same time.
Yeah. So you mentioned using these viral like particles. Have you also looked at lipid nanoparticles?
We are looking into that, yes. The virus-like particles was our first delivery vehicle when we started this project like almost 2 years ago, but now we are looking into also lipid nanoparticles.
Okay.
Yes.
And what have you been able to show so far in the mouse model of Krabbe disease with this approach? Does it work?
Yes, so we have quite strong evidence of correction of the mutation, at least in vitro. So we've tested the platform into cells, Krabbe disease cells, Schwann cells in vitro, and it looks like we have very high rates of correction and production of the protein and correct processing of this protein and correction of neuroinflammation. We have tested these into the mouse model as a biodistribution, and we've shown that we can nicely target the liver, where we have the hematopoietic system in the fetal life. And we can also see actually targeting of the brain, which is a very good sign. And we are now in the process of doing the experiment, which means is gene editing correcting the behavior, neurodegeneration, and survival of these mice after fetal treatment.
Okay, very exciting. So what would the next steps be then? I suppose it depends on the outcome of those experiments.
Yes.
So maybe we should have postponed another few weeks and get those results.
No, we'll see. We'll definitely look into. We will have to check, of course, if the rate of gene editing that we achieve are sufficient to achieve, disease correction. That's the most important part.
Yes.
And then one other areas that we think is really important to explore is refine delivery methods that can specifically target the brain rather than, wasting these delivery vehicles around, the bloodstream and the body of the fetus. So I would say that the line of research that would follow, independent of the results of therapeutic efficacy, is definitely trying to refine specificity of delivery of these vehicles in vivo.
Right, because this can also have massive application for other diseases beyond Krabbe that are also impacting the brain, where you need to get the gene editing cargo. Something I was going to ask you about a little bit later, but it feels kind of like a good time to do it now. What about safety and risk mitigation in the prenatal setting? How do you manage that?
Yeah, so there is safety is an important aspect, especially in this in vivo application, and more importantly when we are targeting a fetus, where we have a fetus and we also have a mother. So the safety risks in this case are linked to the amount of reagents that we deliver in vivo, so the amount which could lead to toxicity, or to try to strike a balance between efficacy and toxicity, systemic toxicity, for example liver toxicity. And most importantly, it's the precision of targeting, the most important aspect in this kind of applications. So we have to make sure we correct the mutation in the right tissues to achieve efficacy, but also we need to make sure we don't have off-targeting, both off-targeting in terms of genomic locations. So we want just to treat that part of the gene, that part of the DNA, but also off-target in terms of tissues. So we want to make sure we are not touching organs that we don't need to treat. And most importantly, we don't have spillage into maternal tissues.
Yeah. How much has been done actually in the field, even by others, in prenatal gene editing? Do we know much about how it typically goes? I mean, are there particular organs that are more likely to be targeted than others, or?
Yeah, so it obviously depends on the route of administration and the type of vector that is used. There are, of course, intravenous is the most difficult to track because it diffuse the vehicles into the whole body, while compared to intracerebral injection, for example. And also depends on the delivery vehicles that we use. If it's a virus, for example, there are AAV that are more brain tropic, other that are more liver tropic. In general, the intravenous route, the majority of the material goes into the liver, which is the first filter organ of the bloodstream. So liver is usually the most targeted tissue. But from other in utero gene editing papers published, which are not many, but there are some out there, I would say liver is the first, and all the organs that are touched by the bloodstream. So it could be heart, could be spleen, and peripheral blood, etc. Of course, targeting the brain is very, very difficult. It's more difficult.
Yeah. If we just go back to, you said earlier that children or babies who are born with Krabbe disease are typically diagnosed at 4 months, but obviously that's based on what you've said today, that's already far too late. So I was just wondering, in terms of diagnostics screening, do you feel in general that obviously there's an ethical consideration around screening for a disease that you cannot provide any treatment for?
Yes.
But if a new treatment was to be on the horizon for Krabbe disease that could be given prenatally, then obviously the screening would have to be implemented to find the patients that would need it the most. So I just wanted to hear your thoughts in general on whether screening, prenatal, and diagnostics at the current time are supportive enough of these approaches to treat these very early onset diseases, kind of more generally.
Yeah. So yes. So there is, for the case of Krabbe disease, it could be easily diagnosed if there was. So usually for this kind of fetal diseases, you would go with an ultrasound check and then see some anomalies, and then you would investigate further, as it happens with any pregnancy, with, for example, whole genome sequencing or cell-free fetal DNA, as we usually do. So that's definitely a route. There is assays to check Krabbe disease in fetuses, and we know mutations, we know the gene that is affected. So it could be, in principle, possible. As you mentioned, it's very important to have a treatment available to justify the inclusion of prenatal diagnostics. We are very far from this to be a reality. We still have problems with newborn screening. Like there are approved gene therapies like Libmeldi, for example, that are out there. They have a market approval, and still newborn screening is just in a pilot stage, pilot test stage. Okay, so we are very, very beyond, I think, the gold standard for this kind of the accessibility of this kind of diagnostic. So as of today, if there was a fetal gene therapy for Krabbe disease available and approved, the only children, fetuses that would be amenable to this would be siblings of children who have been already diagnosed and most probably have deceased in the family.
Okay, because then you would know that the parents were carried.
Yeah, you would actively
come in with an assay.
Yes.
Yeah. Okay. Yeah, so there's a long way to go, but it's going in the right direction. Yeah. So in terms of editing a fetus versus editing a live animal, could you say something about that? How challenging is it to edit the fetus?
Yeah, I mean, I think it's mostly a technical challenge. Of course, we are injecting tiny amount of invisible material into an equally invisible small fetus. So I have to say, my group is not a fetal gene editing group, so this wouldn't have been possible if we didn't collaborate with people expert in this. So actually this project is done in collaboration with a group of Stavros Leokogeorgakis, which is a surgeon at Great Ormond Street Children's Hospital, so nearby our group. They have a long-standing experience in maternal fetal medicine and in utero hematopoietic stem cell transplantation. So they know what they're doing. It requires a huge expertise, a huge technical expertise, and there are very few people who are actually able to do this nicely. So yes, it's technically challenging procedure, but feasible if you have the right expertise.
Yeah. And what about the models? Do you think that the disease models to model in utero gene editing and study the outcomes, are they good enough?
Yes, because at the end of the day, you are going to use animal model of the disease.
Yeah.
The same that you use for postnatal gene therapy. It's just that you are timely mating the mother to make sure they are pregnant at that precise date that you want to use the treatment. So it's not a big deal unless you are working with a disease where, for example, they have breathing difficulties, or there's early lethality even in fetal stage. So then it's very hard, to find the sweet spot between time and survival, let's say.
Sure. Something that I forgot to ask you about Krabbe disease, when you're going with the base editing strategy, is it such that most cases are caused by a particular mutation? There's a single gene involved, right? So it's a monogenic disease?
Yes, it's a monogenic disease, but unfortunately there are tons of different mutations, and the penetrance is not clear. Penetrance meaning that, you have one type of mutation, you are not sure always what's going to be the outcome, phenotypic outcome in terms of symptoms. So it's a very, very complex disease. So our proof of concept is in a mouse model where there's only one mutation type. If we were to go to humans, then there would be a number of mutations that would be treatable with our platform. But there would be other mutations that would need some changes in the platform, such as like adding longer stretches of DNA. But I think our point is really to create a proof of concept of treatment, early treatment of early onset disease, and then you go with refinements in case it works.
So it might be possible to make a one-size-fits-all approach using CRISPR-Cas.
Yes, exactly.
Some kind of approach.
Exactly. Yeah.
Just thinking about, this is very early days in utero gene editing, but in terms of prenatal medicine, it's, a relatively large amount has happened until now. To the best of my knowledge, there are no approved prenatal gene therapies, I believe, but trials have taken place with, for example, prenatal stem cell transfer. There have been proof of concept gene therapies done in larger animals like sheep, who are actually quite similar to us. And there are also a number of, you mentioned one yourself, centers dedicated to fetal surgery. So how much can you leverage the learnings of those studies in your approach? Is there much overlap?
There's not much overlap, but I think, yeah. So when you talk about in utero, people think about it's like a science fiction treatment. There's actually a lot going on, more than we think in utero. So yes, you mentioned that there is in utero transfusion for alpha thalassemia or Rh disease. We have protein replacement for ectodermal dysplasia. We have spina bifida treatments. We have in utero hematopoietic stem cell transplantation. So there's actually a huge bulk of data, clinical data, that can actually inform on potential protocols for gene editing, especially for our approach where we want to inject these vehicles intravenously. This bulk of data is very important because if you think about it, in utero transfusion, in utero hematopoietic stem cell transplant, all these treatments are done by infusing thing intravenously with the very same route that we would use for the gene editing part. So I think procedural risks, so meaning all the risks associated with the procedure itself in the fetus, which would be an ultrasound guided injection, it's covered. There's data that tells you how much it's feasible, the survival, the percentage of preterm birth, etc. So there's actually a lot out there for in maternal fetal medicine that already can help establishing protocol for gene editing approaches. Then gene editing comes with other type of risks, as we talked about already, that will require further refinements.
Yeah, no, that's really promising. And so in terms of regulatory milestones to get a gene editing approach for Krabbe disease, in utero gene editing approach to a clinical trial, what kind of new milestones would you be looking at? I mean, do you have any idea how the regulatory pathway would look right now, since it hasn't been done before?
So I think, so for gene therapy and gene editing in particular, we already know there are some regulatory indications and assays that needs to be performed to bring gene editing to the clinic postnatally. Okay, so we know that gene editing has the problem of targeting. So everything that has been already out there for postnatal gene therapy will be further amplified, for in terms of ethical considerations for prenatal gene editing. So I would say definitely all the safety assessment that you would do for postnatal gene editing would be the same for prenatal. In terms of fetal gene editing, you have a further layer, which is due to the fact that in here you have two patients involved. You have the fetus, which is the patient, and then you have this bystander patient, which is the mother, who will never benefit from the intervention. As such, basically, the health and safety of the mother is top priority. Compared to the simple approach where you would just target a patient. So we have to, in this case, definitely for regulatory milestone, is to make sure to assess the safety, including procedural risks, as I mentioned before, as well as risk associated with the therapy being delivered. So you have to make sure you don't have spillover to maternal tissues, make sure you don't have germline transmissions, for example. You have to make sure that the percentage of preterm birth is very well known, and the protocol be prepared for this eventuality, and also the frequency of pregnancy loss due to the procedure. So I would say it's probably going to be very similar to the gene editing regulation plus another layer of further safety assessment.
Okay, so there's a lot of work to do, but it's very important to do it because, I mean, this could apply to many other diseases. So when we first met about 5 years ago, you were focused on immunodeficiency and inherited immunodeficiency called Wiskott-Aldrich syndrome. Are you still working on immunodeficiencies, or have you shifted your focus now to the early onset diseases such as Krabbe and others?
No, I'm still working on immunodeficiency. So my lab is a lab trying to develop gene editing based therapies for rare genetic diseases affecting children. So we are interested in developing platform for all these kind of diseases without specific interest in one or the other. I think it's very important to develop treatments for immunodeficiency as well as lysosomal storage disorder. I think, of course, there may be diseases with more or less priority based on, again, early onset or not, or other available therapies. Immunodeficiency, in most cases, for this kind of disease, bone marrow transplantation, stem cell transplantation work well. So there may be less urgency in trying to, or priority, let's say, in trying to develop gene editing platforms or gene therapy platforms. For other diseases like lysosomal storage disorder that are very, very serious and not so easy to tackle, I think maybe there's more ground for like innovative therapies.
Yeah. Would you say that within prenatal genome editing that this could be the area? Sorry, I wanted to ask about where you could see prenatal gene editing having the biggest impact. Would it be in these kind of diseases like lysosomal storage disorders?
Yes, I think so. I mean, it's definitely on diseases that are fatal in fetal stage, or of course for all diseases that affect children at birth. But as such, I think inborn error of metabolism, such as lysosomal storage disorders, hereditary thyronesemia, for example, they are all diseases where this would be an amazing approach if it was to work. But not only, there are a lot of for example, cystic fibrosis, diseases of the lung, for example, where intraamniotic delivery, so even less invasive than intravenous, could be an option at fetal stage. Neuromuscular diseases, SMA, for example, alpha thalassemia, also like skin diseases. Again, intraamniotic delivery is actually, has been shown, is good for delivery of reagents to the skin in the fetus.
Can you say a little bit more about that type of delivery, just for anybody who's not?
It's intraamniotic, so you basically you basically inject in the amnio. The opposite as amniocentesis, I would say. There are some rare genetic diseases. I started my scientific life working on epidermolysis bullosa, which is, for example, a horrible disease where basically children are born with skin falling off. Where, for example, prenatal gene therapy would be an option with intraamniotic delivery of viral vectors, let's say. So I think there is a lot of opportunity, and we also must think about the fact that fetuses are very small, and the amount of reagents we have to deliver is very limited compared to what we usually deliver to a baby or a young adult. We know that gene therapies are so expensive that actually, even if we have amazing therapies available and approved, their space in the market is limited. It's very hard to market them. So if fetal gene therapy was deemed successful and safe and something that would be accepted by regulatory agency and by the society, one could envision that we could apply prenatal gene therapy also for diseases that are severe but not life-threatening, or that could be treated postnatally, but prenatally would result in a much cheaper therapy. And therefore more accessible. So I think here the bottleneck is to try to define the feasibility and the safety of this therapy. Then I think there's a plethora of applications that could be benefit from prenatal therapy.
Excellent. That was so interesting, Alessia. We could talk about it for a lot longer, but I think we'll finish up here. You're going to be at the CRISPR Medicine Conference in April, when you're also on the scientific committee. So of course you're going to be there, telling us more about this. Maybe you'll even have some new results to share at the time. And I think it would be great if you will come back later on and tell us about how the experiments are going. We'd love to hear about it. And yeah, thank you so much for taking the time to talk about this really amazing research. And
thank you very much, Karen.
Yeah, have a nice weekend. And also thank you to everybody for joining in. We have quite a big audience today. So thanks for taking the time to sit in, and see you all soon.
See you. Bye.
Take care. Bye.